everyone. It was indeed a great session. We will now start our next session right away, and I request our respected chairperson Dr. Bharat and Dr. David and Dr. Hattori to stay there. Proceed further, please.
Let's move on to birth-related brachial plexus injuries. As the first, Dr. Mukund Tate is not here. It will be a recorded talk. Can you start, please? Yeah.
Good morning, everyone. Honorable chairpersons, ladies and gentlemen. My topic today is nerve repair strategy in global plexus. This is a typical example of a child with global plexus. Notice how the hand has these dimples over here, and there is no movement on anything at all. There are two questions which have been posed to me in this title. One is timing. In global palsy, earlier the better. More time available for growing axons to reach target, while it is still as a viable muscle. So ideally 3 months, 5 kilogram baby in our setup in a global palsy, we will operate. How late is late? I cannot quantify it, but in a baby I am willing to take a chance till at least 1 year. Taking this chance, in my opinion, is preferable to doing nothing in a paralyzed limb. At worst, no recovery will occur, but we need to counsel parents clearly in writing before every operation. We have published extensively on this matter of strategy, and some of our publications are shown over here. So the strategy depends on the number of routes available. If 4 to 5 routes are available, you are really rich. This is very rare, but then directly coapt them to the respective trunk or cord. 3 routes available, 1 each to medial, lateral and posterior cord, and 11th nerve to suprascapular. Remember, the medial cord gets the best route always. Hand is the priority in our birth plexus. 2 routes available, route 1 to lower trunk medial cord, route 2 to lateral cord, or shared between lateral and posterior with 11 to SSN. Some authorities would prefer route 2 to a posterior division of upper trunk and 2 to 3 ICNs to biceps. Their point is getting a strong triceps and a stable shoulder with deltoid and triceps as well as rotator cuff is important to balance a well-recovered biceps. One route available, route to lower trunk medial cord, plus 11 to SSN, plus 2 to 3 ICNs to biceps. But this is also an indication for contralateral C7 if the route is not convincing. I'm sorry about the spelling mistake. So the strategy we use in 0 or 1 poor route is contralateral C7 to C8T1, 11th nerve to MCN, cervical motors to suprascapular nerve, and whatever poor root stump is available to posterior division of the upper trunk. So this is a typical reconstruction with plenty of roots. This has been done in 2016. C5 to PDUT, C6 to ADUT, that means anterior division of upper trunk, C7 to C7 and C8T1 to C8T1. This is really, really great because all roots were available. And the typical result of such an operation, we get pretty good results. In this particular case, the hand is not the most impressive, but it is still quite reasonable. This child was injured at the age of 1 year. This was not a birth plexus. And then we coapted it within about 2 months. Two-year follow-up of one root, early hand function. This changes over time. Here we have given 11 to posterior division of upper trunk, including SSN, and C5 shared between anterior division of upper trunk and C8T1. Today I probably would have done pretty reasonable result, but I probably would have done a contralateral C7 in addition. a complete reconstruction with 2 routes. The strategy is written here: 11 to SSN, C5 to anterior division, C6 to posterior division, and C5-6 also used with 4 cables to C8. See, the initial result looks quite poor, but these results improve over time. This is the same child. This is a 4-year follow-up. These are still showing the upper plexus recovery. And this is the same child, which is a longer follow-up, 7 and 8 years. You can see a Raimondi 3B kind of hand, where she can grip and release. And a year later, that hand has improved further, where now she is doing skilled activity like putting a button. And finally, something as skilled as eyeing a needle. So these results change over time. What you see at 1 year will not be the same as 8 years. No root or one root use of CC7. And the following slides show sample results. I have already discussed this strategy earlier. So this is the earliest result. You can see a MRC3 flexion, but this is not how it remains. It improves over time. Same child, which I showed you in the earlier, now 10 years old, see the level of skills and the change that has happened. And the same child in March 2024. Once again, results change over time. This child is our longest follow-up. This is his very, very first result, some hesitating movements of the hand. And then we come to a 19-year follow-up. He is now a medical student. The same hand, brushing, complex activity like putting on a watch, wearing his gloves, and finally using that same hand to do a cadaver dissection. I thank you for your patience.
And so they're amazing results, obviously. Unfortunately, we don't have Dr. Thad here to discuss the paper in person, but has anyone got a comment? We've got some very experienced surgeons here in the room. Personally, we don't see, I was discussing this the other day, we don't see this sort of palsy in Australia. It's very rare for us to see a complete palsy. It's obviously a different disease that we're looking at in the local environment. So I'd like to ask my co-chair, Dr. Kadati, to present on approaching extended palsy comprehensive management. Thank you.
So we move on to the next group of patients. Approach to extended brachial plexus birth palsy. So let's look at understanding extended palsy. Let's look at the past and the present, early and late presentation, and case examples with outcomes. It's my original work and I have no disclosures. So let's have a corollary here. The so-called extended 5-6-7 palsy in children who do not recover spontaneously should be treated as near total or total palsy. This is the classification, 1, 2 and 3, 4 Narakas. So what we are looking at in extended palsy is group 2 and group 3, either a flail extremity with a, or a flail complete palsy with a T1 kind of hand in group 3. So these are the two groups we'll be addressing now. This is a classic patient with extended palsy, as you can see here. He's got a weakness of wrist extension, a flexion, wrist flexion attitude, and there is flicker of finger movements, as you can see that. This is a classical extended palsy. So the timing, what I do is in a 5-6-7 presentation, I wait for the recovery of biceps and wrist extension by 4 to 6 months. If they don't recover, I go on and explore and do a primary reconstruction and nerve transfers. In a Narakas 3 and 4, where there is a complete palsy, I wait for the recovery of biceps and recovery of wrist and hand function by 3 to 4 months. If they don't recover by 3 to 4 months, I suggest exploration and primary reconstruction. The decision can also be taken based on the Toronto score. That is, if the Toronto score is less than 3.5 at 3 months or older, is an indication for microsurgery. Now, strategy I follow is whenever 3 routes are available, I use the best route to the lower trunk. The next best route is the anterior division of the upper trunk, the C7 to the middle trunk, and the spinal axis to suprascapular. That's the best possible thing to do. And if you have 3 routes available, you can neurotise all the 3 functions: shoulder, elbow, and wrist. If there are only 2 routes available, I use the C5 to the lower trunk, C6 to the upper trunk, spinal axis to suprascapular. If there is only 1 route available, I use the best route for the lower trunk, intercostal to musculocutaneous for elbow flexion, and spinal axis to suprascapular for shoulder function. If there are no route available, then I use the contralateral C7 for lower trunk, spinal axis to suprascapular, intercostal musculocutaneous. That's my strategy in a total palsy, but today we are discussing extended palsy. Now, this is a child operated 7 years post-op result of a total primary reconstruction of a total palsy. You can see that although there is improvement in the shoulder abduction and external rotation, a primary reconstruction was done. The 3 routes were available and the nerve grafting was done. There is independent improvement in the shoulder and elbow function, but you will be able to appreciate the weakness in the finger extension in this child. The wrist and fingers are flexed. Although he is able to grasp, there is attitude of flexion and there is weakness of wrist and finger extension. The most difficult function to achieve in a brachial plexus birth injury is the wrist extension and finger extension, and that is the most useful function, because once you achieve that, you will be able to achieve the grasp. So how do we improvise on achieving the wrist and finger extension? Let's go ahead and see. The difference in compared to adults is, fortunately, avulsion of all routes are rare. Children have a high regeneration potential, low velocity injuries, and ipsilateral route can be directly mobilized for a direct transfer. The advantage of using a direct ipsilateral route is reduces the nerve grafts, minimizes axonal fallout, it is a single anastomosis, and gives better outcomes. A classic presentation is 2 routes are available here. The 5 and 6 are ruptured, 7 and 8 are avulsed, and T1 may be intact because I told you extended palsy. So what I do is try and get at least one of the routes to direct connection to C8 and T1, and other route I can use the nerve graft. As you can see in the clockwise direction, if you go, freshening of the C5, looking at the fascicles in the C5, freshening of the C8, and looking at the fascicle in the C8, and approximation in the last video, you will be able to see the approximation of the C5 to C8 directly, ipsilateral route directly. That gives better wrist and finger extension. And for example, look at this child, no shoulder and elbow function. You can see the flicker of finger flexion, the classical extended palsy, I would say. So this child had a rupture of the 5 and 6, avulsion of C7, avulsion of C8, and T1 was intact on exploration. So what I did was I used the C5 with a nerve graft to anterior division and posterior division of upper trunk, C6 to C8 direct anastomosis, and spinal axis to suprascapular. Upper trunk nerve grafting, C6 to C8 direct anastomosis, and then use the spinal axis to suprascapular. This is 8 years post-op video in this child. Independent shoulder abduction, independent shoulder external rotation, independent finger and wrist extension. Independent elbow flexion and elbow extension. And you will be able to appreciate the improvement in the wrist and finger extension in this child, as you can see that. Originally a T1 hand. And this, another example of a extended palsy. As you can see, there is no shoulder and elbow flexion, and the wrist is in a flexion attitude. There is no finger extension and wrist extension. Flicker of finger flexion is there. So it's a T1 hand. So what I did is use the C5 to C8 directly, spinal axis to suprascapular, the C5 to C8 direct anastomosis, ipsilateral route, spinal axis to suprascapular, intercostal to musculocutaneous, as you can see this, intercostal to musculocutaneous, and that's result you can expect. Independent elbow flexion, independent elbow extension at the right hand, hand to mouth, and that's the kind of hand function you expect. Independent improvement in the child can grasp objects. C5 to C8 direct root transfers. Now, what do you do when they present late? Now, this child presented at 18 months with a poor external rotation of the shoulder, limited abduction, no no, limited elbow movements, and there is no finger and wrist extension if you can see. The slight flicker of finger flexion, but there is no extension. As I told you, the function of the hand will certainly improve only if there is finger extension and wrist extension, because the grasp improves. If that is not there, the whole function of the hand is compromised if you don't improve the finger and wrist extension. So what did I do in this child? The child can only, if you push an object, it can grasp, but otherwise it can't open and grasp an object. So what did I do in this child? I did the spine laxity suprascapular for shoulder abduction. I also did the anterior shoulder release. And I also, what I did is I used the intercostal radial now for improvement in the elbow extension. There is the triceps, wrist extension and finger extension. As you can see that. Independent elbow flexion, independent elbow extension. And you can see the child is able to open up the wrist and the fingers to grasp object. So you can significantly improve the improvement of the function, because when two roots avulsion, you can see the improvement in the mallet and the Raymond score with the nerve graft as well as direct root transfer. So improvement in mallet scores is by 15%, by Raymond scores by 25%. So it is possible to mobilize at least one ipsilateral root for direct transfer in many of the children. Direct root transfers give better outcomes. The so-called 5-6-7 in birth palsy is practically 5-6-7-8. It is not just 5-6-7, because many a times if it's only 5-6-7, the spontaneously will recover. But if it goes beyond that, when the 8 is involved, they do not recover and they need to be treated like a total palsy. And intercostal radial now is promising in delayed presentations. Thank you, Vinod.
Do we have a question?
So that was a great paper. Except the last case, all of your cases have very poor triceps. And triceps have biomechanical implication in shoulder elevation. So you are happy with shoulder at 90 degrees. But could you, renervate triceps at the outset? Because that's very important for shoulder motion.
These patients, what we do is we retrain them. So once what happens is it's just weak, it is not absent. You just put them on elbow splint, the triceps improves. You just put them on elbow splint, your shoulder abduction improves, and then strengthen the triceps over a period of time.
So that's a myth, I have devised that test, elbow block test. We have been using that for years and years. It doesn't improve the tricep strength. So I talk to our plastic colleagues that we must do something to re-innervate the triceps, because the only option to augment triceps is to take brachialis or to take lower trapezius, which are, again, the lower trapezius doesn't give great outcome.
Yeah, that's what in children, that's what I'm doing now. Intercostal radial now, which innervates.
Yeah, so that was the great, the point I took from your talk.
Thank you.
Thank you very much, Parth. And our next speaker is Dr. Ashwath, and talking on nerve transfers, indications and outcomes in birth-related plexus palsy. Thank you.
Good morning. I'll be continuing on the same thing which, most of the work which I do has already, Bharat sir has already told a lot about that. So basically what we see, the natural history is the partial recovery which we see with C5, C6 anti-gravity strength in the first 3 to 6 months. Invariably it leads to some form of permanent progressive limitation, and around 10 to 30% of this will require surgery. So we follow this classification, and more severe the injury, as you see, the group 4 Narakas, invariably all of them will end up with surgery. And so the option is to go by the standard approach of exploration, nerve grafting and nerve transfer. And I particularly would like to stress on the concept of nerve transfer, which has made a crucial difference in the recent times. So obviously it's the only option, the main benefit, the only option for avulsions, and no early downgrade of function as the neuroma is not resected, and a shorter distance for regeneration and reinnervation, and this is the only option in late presentation. And particularly in the type of cases which I see, where we see a lot of severe co-contractures, late presentations, and there the nerve transfers is the only option. And of course, the shorter duration and lower technical complexity. Obviously, this is an easy point. Surgery is an obvious need for this. And also, children who come late with severe co-contraction, and even a little older children, 2-year-old child who has very poor elbow flexion. So the late presentation with severe contracture are some of the additional recent indications which I thought are where nerve transfer is needed. So this is what commonly we do. Dr. Bharat has already told about this. So where we do this at around 4 to 6 months time. And if the child is not able to do it, we start thinking about surgery. So we follow them serially, these children, at 1, 3, 6 and 9 months. We do the AMS score, the towel test. This is the crucial period between 3 to 6 months. And if that test score is below 3.5, then we start thinking about surgery. We start counseling them for surgery by around 6 months' time. So MRI electrodiagnosis are some of the common, but usually most of this are not, I don't use them very frequently in our practice. Ultrasound, yes, for shoulder joint in recent times, and also for assessment. Recent reports are there where they talk about ultrasound to diagnose plexus injury. So this is what generally what we do. We are lucky, sometimes we find the root, but the moment we get a picture like this where near the phrenic nerve you obviously see the C5 root is in a very bad shape, very severely scarred, and obviously you won't find a root, viable root in such situations. Even the C7 is avulsed, as you see here. So in that situations, obviously you start thinking about surgery. So the options are similar to what Dr. Bharat had already told. So if the roots are available, we usually target the middle trunk and the posterior division of the upper trunk. So as Dr. Shah had just told, so the target for shoulder and elbow triceps is very, very important. And usually we will rely on nerve transfers to get elbow flexion and shoulder external rotation. And sometimes we use the cervical sensory because sensation on the radial side is very important. So we use a sensory nerve transfer also if we don't find the viable root. The same thing applies for extended palsy, so I won't talk much on that. Now this is one point which has been of late, a lot of work has been done where very selected nerve transfer, Dr. Bharat has already talked about it. So where you can, in late cases, we can do some nerve transfers. For example, in severe co-contraction, there is a report on where we do a nerve transfer to correct that and also for to get external rotation. So these are the standard nerve transfers we do, spinal extensor suprascapular, Sohm-Sachs procedure, we all know that, Oberlin's obviously, and the intercostal. So these are the three standard workhorse nerve transfers which we rely on. And of course the nerve graft from the native roots, and also in select few cases we have done for antegrade and also retropharyngeal root of transfer. So post-operatively we immobilize in an arm chest bandage, and then subsequently the hand therapy program is started. Now select few examples. So here is an example of a breech presentation. Invariably we know that these are cases which will go for avulsions. So subsequently they have, we've done a nerve transfer on the left side, right side spontaneously recovered. So they have the nerve transfers are a usual option for in such situations. So this is some of the follow-up we see. This is again one of the examples of an extended palsy where we did the sural nerve grafting for posterior division of upper trunk and middle trunk. We did the Oberlins and the spinal accessory to suprascapular nerve. Now again in T1 hand is again an example where we do the nerve grafting and the nerve transfers. Now the main option for nerve transfers invariably we introduce is to break the cycle of co-contractures. So that is one thing which we always think about. So and subsequently we did a tendon transfer and we have a reasonable result. Now this is the other child which I showed earlier, in a little older child. Now see the abduction which improves. So this is only an intercostal nerve transfer we have done, and he has a reasonable elbow flexion and a very good control of the elbow. So we have around 12, this was presented last year where we had 4 patients with upper extended palsy, 3 with global palsy, and with an average follow-up around 2 years. And subsequently we had a very reasonable results where 51% improved on the AMS score and the range of movement also improved. So in the literature also talks about the recent trend towards the beneficial effect and the superiority of the nerve transfers. So particularly Tate sir has one paper recently which was published. So in effect I would like to stress on the important point on the need for nerve transfers in obstetric palsy. So it's one of the important part of the armamentarium to reconstruct the plexus in pediatric age group. Thank you.
Thank you, Dr. Ashwath. Any questions to Dr. Ashwath? Although there was some repetition, I'm sure we have driven home the point. Yes?
I was just going to ask the issue with nerve transfer. I see you're doing a combined grafting plus transfer, which I think is probably the way to go, but the sensory deficit on the radial side of the hand, what have you got a comment about when we're just, apart from the case you mentioned where you transfer in the global plexus palsy, have you got a comment in the partial plexus palsy where you're relying on motor nerve transfers and the consequence for hand sensation?
Yeah, invariably radial side, particularly in extended palsy, if a route is available, yes, we do provide a graft to the anterior division of the upper trunk, but usually it's in the posterior division of the trunk. So we do have some sensory deficit, but what we see in those patients is they don't have a major ulcers or any nail defects in these children. So they do well with the nerve grafting.
Primary nerve grafting. Yeah.
Primary nerve.
Yeah. Thank you, Dr. Ashwath. We move on to the next challenging set of patients. Contralateral C-section outcomes evaluating results by Dr. Joshid Balan.
Good morning, dear chairpersons, dear seniors and dear friends. So I'll be talking on contralateral C-section transfer retrosurgery in birth brachial plexus injury. So we already know that in case of Erb's palsy and some amount of extended palsy, this nerve transfers will do magic. And in case where there is extended injury cases with positive nerve roots, we have to bang upon some other ipsilateral extraplexal, contralateral extraplexal and contralateral C-section because we had to get more number of axons recruitment. So our aim is to get early neurotization and more axonal recruitment. Early neurotization, is possible by early surgery and reducing the length of the graft, and more axonal recruitment is by recruiting more roots, because each contractile C7, it contains around 20,000 to 40,000 axons, and we had to get more cable grafts to recruit all the nerves into the target nerves. So contractile C7 transfer usually is mainly done in two methods. One is subcutaneous transfer and its other is retroesophageal transfer. So subcutaneous transfer is comparatively easy, dissection is easy, and technically is less challenging. And but the only disadvantage that the nerve graft required is more. And retroesophageal transfer technically is little challenging, and the graft length can be reduced, and more number of cable grafts are the byproducts when you reduce the number this length of the graft. Because here you can see when you do subcutaneous transfer, this is the length of the graft, and when you do retroesophageal, the length is reduced. So earlier studies have shown that around when you do subcutaneous transfer, the length of the nerve grafts used is around 11 centimeter, and when we are doing it retroesophageal, it is reduced to the length is reduced to 4 centimeter to 4.5 centimeter, so that we can make it into 2-3 cables extra from single graft. So we'll get more number of cable grafts. That is because especially in children, we don't have in neonates, we don't have the length of the grafts are very less. And surgical steps, as we had to explore the neck and we had to see, and we had to go the contralateral side. Here, this is the contralateral side. This is the posterior division, the lower one, and the anterior division. Posterior division of the middle trunk will be joined by the posterior division of the lower trunk. There is a limit. Till that level we can go. So if you we should be careful that not to injure that posterior division. So anterior division, sometimes we may be able to go little more further. And we'll be transferring it to retroesophageally, and we have to take it, this is scalene, we have to take it posterior to the scalene anticus, so that you will get extra length. So you take it through this course, and you in children, in adults actually, we'll be able to take all the nerve up to the opposite side. Actually in children, the neck width and shoulder width, this proportion is different. So this sometimes still be coming to the posterior aspect of the esophagus. So we may have to do the coaptation retroesophagally. So and this is the tunnel we have made. Retroesophageal, we put a Riles tube, and with the help of the Riles tube only we'll be taking it into the ipsilateral side. We cut it, and with the negative section we take. So we take both sural and saphenous nerve. Now we'll go to some of the case scenario. This is a 8.5 month old child. You can see she doesn't have much of movements, only this finger flexion is there and some movement is there. So on exploration we could see that all C5 to C8 roots were avulsed, and only the T1 was intact, T1 hand. And we have done nerve transfer in the form of spinal laxity to suprascapular nerve. Contractile C7 was connected to the anterior division of upper trunk and posterior division of upper trunk by 3 cable grafts each, and it was connected to C8 by 4 cable grafts. This is her results: elbow flexion at 2 years and 7 months. Now she is able to take her hand to the mouth. This shoulder abduction, she is having good overhead shoulder abduction. Then you can see her shoulder and elbow stability. That's also important, because she is able to control both shoulder and elbow. This is her wrist function at 2 years and 7 months. Finger flexion, and she is able to do the pencil grabs. She is able to take small objects from the follow. So we have to wait, as that is always seen. When you wait, you can see the results will be improving. Her hand function. This is earlier. This was around 2 years 9. This is 3 years 6 months. So elbow flexion. You can see the hand also, external rotation. She is having wrist extension. Her wrist control is improved. So we have to wait for these results, especially in extended case and pan plexus cases. And this is another child, 3 months. This is the hand function. So on table there C5, C7, there was no roots actually. Only C8 was intact. Spinal laxity suprascapular nerve transfer has been done. Oberlin transfer has been done, and C7 was connected to the anterior and posterior division of upper trunk and middle trunk through grafts. This is results around 7 months. These are results 16 months. Elbow flexion, external rotation, shoulder abduction, and shoulder and elbow stability. you can see her strength of her grip also. She is able to control her grips. She's trying to grab a chocolate from the child. And in another child, it presented Plexus injury with the Horner syndrome, 3 months old. So on operation, we could find that C5 was found to be ruptured, and C5, C6, C7, C8 and T1 was found to be avulsed. C5 was connected to the anterior and posterior division of upper trunk. Contralateral C7 was connected to the lower trunk, and the spinal laxity to suprascapularis nerve was done. This is the 3 post surgery. You can see the elbow flexion. You can see there is a fixed little flexion of the wrist because there is not much extension. This is external rotation, shoulder abduction, and because he is having good shoulder stability and elbow stability, that's also important. He is able to take his hand behind his head. So hand, you can see there is a wrist function is there, wrist flexion is there, and this is wrist finger flexion. So we are waiting for this. If there is no improvement, we are planning to do tendon transfer in such cases. So it's another child. C5, C6, C7 was found to be avulsed, and C8 was found to be fibrosed. This is the clinical picture in the pre-surgery. So neuralysis of C8 was done. Oberlin transfer, spinal laxity, suprascapular nerve, and opposite C7 was connected to anterior and posterior division of upper trunk and posterior division of middle trunk, and you can see abduction, flexion, and good shoulder and elbow stability. Extension part is little lacking, so we had to wait for it to improve. So what do we achieve while taking the nerve retroesophagally? Because we are getting more recruitment of the axon, because number of cable cars we are getting is more, and we get early neurotization because that length of the grafts are reduced into 1/3, and as Sir was mentioning, more sensory recovery we will be getting. Because, and another thing is that for the growth of the upper limb, there should be a connection between the nerve, this upper limb and brain through the nerves. So while concluding, when there is a paucity of nerve roots on the ipsilateral side, contralateral C7 transfer through retroesophageal route appears to be the most appealing surgery to renovate the plexus. Thank you. It has been already been published this year. And I would like to invite all of you to the next Brachial Con. It was conducted in Thrissur in 6th and 7th. That's one of the good.
Thank you, Dr. Joshit.
Thank you.
Any questions for Dr. Joshit?
When you take a retro
Yeah.
esophageal, any challenges you face?
No, luckily so far we have done more than 50 cases in adult and more than 20-25 cases in pediatric. So still now we have no challenges we have. Only challenge is that in this length only. In pediatric, this length we had to do that coaptation. Sometimes we had to do it retroesophagally. That is the only challenge we used to get. That bleeding and all other kind of this one we are not get.
So, Dr. Joshit, yeah, I have a question.
Yes, sir.
Normally when you target the function, it's one donor for one function.
Yes, sir.
So what you're using is contralateral C7
Yes.
for multiple functions.
Yes, sir.
Your upper trunk and middle trunk, upper trunk and lower trunk, that
Yes,
way.
yes, sir.
So how are you able to re-educate these children?
No, because the beauty is that this children's brain, this plasticity is better when compared to the adults. So they evolve, they relearn, and so.
Do you involve them in any
Yeah.
specific rehabilitation protocol?
No, actually, we don't put into it specific. They themselves actually we will ask them to get some toys, some small toys for extra toys actually. So they'll let them play more, so they'll get more physiotherapy. That's our protocol.
So just a comment, we in Australia we don't see that level of injury as frequently, obviously, and we don't have the experience with
This kind of
cross-neck
injuries, yes, sir.
donor, and it got a bad reputation in the adult plexus group at home because the results were poor and patients struggled to use it independently. But the results you show in terms of the spontaneous use of the hand are just fantastic.
Yes, thank you, sir. Actually, it's a good team we are having, so that's the reason. Our team is very good.
Do the children go through a period where they have to activate it with their other arm before?
Yeah.
They
No,
develop
no, actually
spontaneous
that's
use?
no. In adults, whenever we are doing in adults contractile season, we had to induction exercise we had to do with all the types of exercise we had to do in adults. But in children, they themselves learn actually. That's what we have seen.
It's remarkable. Fantastic. Thank you.
Thank you.
Congratulations.
Thank you very much, sir.
So our penultimate speaker is Dr. Shah, Moulin Shah, who's going to speak to us about shoulder deformities in brachial plexus palsy.
So thank you, Bharat and team, for inviting me. So I'm a bit odd in your group. I'm a pediatric orthopedic surgeon. I will talk about shoulder rebalancing in palsy, and that will be two subsections. We should start thinking of shoulder rebalancing since infancy. And in older children, there's two subgroups I'll talk about. Is typical Erb's palsy and extended palsy. We know that why interrotation contracture develops in children. So far, we thought that it is because of the muscle imbalance and the time of recruitment. But our colleague from Cincinnati, they also found that the muscles which fail to elongate, the denervated muscles fail to elongate. What this imbalance leads to altered biomechanics. Be you a plastic surgeon or a plexus surgeon, you must be aware of this biomechanics, because this leads to the movement which may be mistaken that the child is not recruited, but that recruitment, the muscles are working, but biomechanically they are not strong. And so Howard Clark recently published that some of these patients, when you treat them early for interrotation contracture, you can obviate the nerve surgery. So what's the right way to measure passive external rotation? What degree of passive external rotation is worrisome? It's not the right way that you take an infant in sitting posture, because they have a lot of compensation. The right way is to check in supine position to prevent scapular compensation. And we have published that any passive external rotation less than 40 degrees with the presence of deep anterior crease is equal to shoulder subluxation. We have proved through ultrasound diagnosis. So once the child has reduced passive external rotation, you look at the anterior deep crease and the short arm segment in very severe cases. And ultrasound will show you posteriorly subluxed the humeral head when the alpha angle is more than 30 and ossified humeral epiphysis behind dorsal scapular line. It is termed as posterior shoulder dislocation. So what we do in this children, this 8 months old child with a limited abduction and arm is always in internal rotation posture, and you can see that the child cannot hold the position well. There is no external rotation, and persistent posture is this. There is deep anterior crease, and on ultrasound it revealed shoulder dislocation. We tend to take them to theater. We do close reduction by manipulation. We inject subscap and pec major with Botox, and intraoperatively we confirm the relocation with an ultrasound, and we put them in shoulder spica. And many of these children, you can avoid subsequent nerve or shoulder rebalancing surgeries. So they remain in spica for 3 weeks. And the follow-up of this child, you can see the child has good external rotation, good abduction, and we could avoid any further surgery. So this can be, we studied the result of these 95 patients we injected over 12 years, and with 62 patients more than 3 years follow-up, we could avoid for subsequent surgery in 44% patients. And in 44% patients, we require shoulder rebalancing, and in 12% patients, they developed external rotation contracture. When we look at them, they have weak triceps or weak wrist dorsiflexors, so they have extended Erb's palsy cohort. So we are now avoiding Botox in extended palsy patients. Now coming to older children, shoulder rebalancing in Erb's palsy, we know the conventional treatment is to release subscapularis and internal rotation and transfer conjoint tendon to infraspinatus to balance the shoulder. But management actually depends on the congruency of glenohumeral joint, and Peter Waters from Boston gave this classification, where if it is a glenoid retroversion or retroversion with subluxation, this is still a congruent glenohumeral joint where the soft tissue procedures would work, like interrotator release and transfer. And we published our result that in cases we do it a minimally invasive way, wherein we turn the arm internally and forward flexion position and make the medial border of scapula prominent. We put a centimeter incision at the junction of upper 1/3 and lower 2/3, and then with an artery forceps we go to rhomboids to the undersurface of scapula. and with a 5 millimeter and 8 millimeter periosseal elevators, we slide subscapularis from the anterior surface of scapula, and we stretch the shoulder. And this procedure takes 5 minutes. It's very short and equally effective when we looked at our result at medium term. And we don't need anterior open release in most of our cases, and we avoid arthroscopic release because that has shown to induce anterior instability. So in 5 minutes, you can achieve this external rotation. And results after shoulder rebalancing in congruent glenohumeral joint are as expected. They improve their posture, they improve trumpeting. And so this can be done at any age. I have treated an adult with 22 years old with shoulder imbalance with congruent glenohumeral joint with MISR and tendon transfer. But if the child has a false glenoid or complete dislocated shoulder where there is non-congruous glenohumeral joint, this soft tissue procedure may not work, and you may have to resort to glenoid anteversion osteotomy or a humeral osteotomy. Of course, there are some exception to this. There are the young children, less than 5 years. We have seen significant remodeling. For instance, this boy is having persistent internal rotation arm posture, presented to us for the first time at 2 years and had type 4 waters. And we did minimally invasive subscap release and tendon transfer, and you can see the outcome. His abduction, external rotation improved, arm posture improved. And if you see the MRI at 1 year follow-up, we could restore normal glenohumeral articulation, by meaning that the glenohumeral remodeling is exceptional in children less than 5 years. Let me take you to an older child with congruent glenohumeral joint. This is the highest degree of trumpeting I have seen in my life, 180 degrees trumpeting. Okay, but still he had congruous glenohumeral joint, and we did MISR and tendon transfer in the same patient, and we could see good degrees of external rotation and release of trumpeting. And the message is, if you have congruent glenohumeral joint, any degrees of trumpeting can be treated. But children with non-congruous glenohumeral joint with an advanced age like this, 9-year-old girl, we tend to do glenoid anteversion osteotomy to make the joint where a soft tissue rebalancing would not work to a point where it can work. So this is the outcome of that girl, and you can look at the one year follow-up where the glenoid articulation improved. And the children were adolescent with significant dislocation, we do derotation osteotomy, which is a very easy operation, but you are not altering glenohumeral articulation and keep it there for lifetime. So in summary, we do look at the congruency. If it is congruent, you can do soft tissue balancing at any moment. Children less than 5 years with congruent glenohumeral joint, we do soft tissue rebalancing. More than 10 years, we do osteotomy. And between 5 and 10 years, I would do glenoid anteversion osteotomy. A few slides about extended palsy. So, what are extended palsy? They present when they are not treated. We have a treasure of untreated extended palsy patients. And when they grow up, they have good external rotation, but they have poor abduction. This girl has good active and passive external rotation, but when you ask them to elevate the arm, she will be stuck at 90 degrees and she will not go up. And the moment you put an paddy wrap, or we term it as an elbow block test, there is spontaneous improvement in abduction, meaning that their deltoid are very much innervated. So what is producing this improvement while putting an elbow extension splint? We did a CT scan study over these patients, and we found that when they try to abduct at 80 or 90 degrees, there is anterior subluxation on CT scan. Subscapular is being supplied by C5, 6, and 7. It is a very important anterior restraint. It is weak in this patient. This leads to anterior subluxation. And unlike other C5, 6 patients where they have posterior instability, these patients have anterior instability. The moment you put an extension splint, they will improve in their shoulder relocation, their abduction would improve. But Bharat, we cannot keep them having only elbow extension splint for lifetime. So what we do pectoralis major, clavicular head transposition. We took it from origin insertion, we shift it to the greater tuberosity, and we plaster them like this. And this, in a cohort of 70 patients we have done transfer, we have found average improvement in abduction over 45 degrees. So you can look at this child with pre-surgery abduction of around 45 degrees, with an abduction improved to full with an extension splint, and then we have done pec major transpositioning. In this particular child, she also had external rotation contracture, and we required arthroscopic posterior capsule release, but her abduction improved to this extent, and now she is 10 years. Another child with elbow extension splint, you can see abduction is full, but so this is typical of extended house palsy. Last slide. Yeah. So they are flexed elbow and abducted arms. So we have done pec major transposition, and now the triceps is very weak. So we did triceps augmentation in second stage by transferring brachialis to triceps. It's not biceps, but brachialis, which is responsible for co-contraction. So we spare biceps and we shift brachialis. And this concept was coined by Dr. Chuang. So extended palsy needs multiple staged, multi-level surgeries, and ultimately we can help them. So restriction, abduction, and good external rotation, you do elbow block test. If improvement is more than 30 degree, there's anterior instability, and you do pec major transposition with or without triceps. And if it is not improving, that's deltoid paralysis, and you may go for pec major with trapezius to deltoid. This cohort has a relatively poor outcome. So thank you very much.
Thanks, Milan. Fantastic results. Have we got any questions?
Yes, sir.
You said that pectoralis is a static stabilizer. David Chong does the same thing for
Yeah. Yeah. So the Dr. Chuang's purpose of surgery, I had a very detailed discussion with him, and where I shift is more onto the more superior and lateral to the greater tuberosity cartilage. The purpose is when we suture it in internal rotation and abduction, and the moment we bring the arm down and externally rotate, that becomes it becomes tight. And that's how we believe that stabilizes the shoulder joint in front. We have conducted the CT scan studies after pec major transpositioning, and then we have found the amount of subluxation has reduced. So that's how it works. Dr. Chuang has done transfer with the concept of co-contraction, that pec major and abductors co-contract. We have done surface EMG, we have not found any co-contraction. But 1 year after this surgery, they start co-contracting because of the motor relearning.
Yeah,
so we will talk later.
Thank you. Discussion with Molin can go on. Yeah, we got a next speaker, David Macomb, President of the Australian Hand Surgery Society. He will be speaking on limb motion measurement, assessing both brachial plexus palsy.
Thank you very much. As I said yesterday, we really appreciate being invited as a guest society. It's been a great meeting, and I've learned a lot, particularly in this session. So this is a quick paper on a attempt we had at trying to develop a tool to measure shoulder motion more accurately. So no financial disclosures. Functional assessment in plexus palsy, baby plexus palsy, we all use a Mallet score, but we find at least that it's relatively, it doesn't discern change very well, and there are children who are clearly poor and children who are clearly great, but there's a big group in the middle where I don't think this scale necessarily is super helpful. You can go to the Gait Lab and do 3D motion with multiple Vicon cameras, but that's not really practical for clinic use. But that's very useful and very accurate, obviously. So we aim to try and develop a tool, and it had this concept of trying to measure the volume of reach and the shape of that balloon of reach as a measure of shoulder function. But we wanted it to be simple, objective, and measure data continuously rather than a 1 to 5 scale. And we wanted it to see if we could measure, make sure it was responsive to our interventions so that we could measure outcomes of surgery. So we had this idea of this volume of reach balloon. We had that idea for a long time, and then we had a fellow turn up from the US in the orthopedic department who had worked with Doctors Carrillo and Han, and they'd been using a Microsoft gaming system called Kinect not in this plexus palsy group, but in other neurological conditions for motion capture. And it's an infrared system, and it's used as a gaming system so that kids can sit in front of a TV and move, and their body comes up on the scan, and it's not as accurate, obviously, as a Vicon motion capture gait lab system, but we thought it might be useful because it seemed simple. This is a kid in our clinic standing in front of a screen, and she has her shoulders and limb digitised, and we can get her. That's actually my son on the phone who was doing some research with us, and he's demonstrating to her what movement we want to achieve. So this is what happens, and there's some complicated mathematics that come out the other side of the machine that allow us to create a volume or a sphere of the range of motion. And so this is normal, the normal side, and you can see here that this is a child who's had a plexus injury, who's got a limitation of abduction, probably needs a pec major transfer. Interestingly, in the picture on the right, you can see the loss of midline function, which is, I think, particularly critical in these children. So we did a pilot study where we got a group of 20 kids and did this imaging with them. We looked at their height and their reach of their unaffected arm, and that was relatively, that the balloon we were able to construct was proportionate to their height, so that was relatively consistent and served as an internal control. And then we looked at their affected arm, and you can see that the red dots, which are the data from the affected arm, and that's this volume of reachable workspace type balloon, were largely much poorer than the normal. And so that when you standardise that for the height of the child, that comes out as showing a significantly reduced volume of reach. And it correlated with the Mallet score to some degree, but you can see that there's this clustering effect in that sort of 3 to 4. So they're not bad, they're not obviously terrible, but they're not great. And it doesn't really discern, but you know as a clinician, and the child knows and the parent knows whether they've made much difference. And I always found it pretty disappointing to operate on these kids' shoulders and try and think that I've done a great job, but then when you do a Mallet score, they might have moved 1 point. So we were looking for something to try and become more discerning, and that's to the point of that. So the other advantage, apart from calculating this volume of reach balloon and the shape of it, is you can actually trace specific joint movement, and this is you can see in the lower set of diagrams that the path of movement, and it's this child's demonstrating some trumpeting with the affected arm, and you can specifically measure paths of movement, and we did look into some of that as to defining the abnormality of the path of movement. So this Connect system is easy to use. You can do it in clinic, and you can make it a part of your regular assessment, and so that's great. And we thought we were on a winner. Unfortunately, the mathematic part of it behind it that takes the data from the there's two things that have happened. One is that Microsoft have moved to a different gaming platform, so they don't make it anymore. But you can buy it on Amazon and those internet web-based marketplaces. But the problem we've got is that the mathematic part, the sequence of calculation that takes the raw data and creates the spheres and the measurements has been privatised by the university in the States, and so we're trying to work. We've got to go back to the drawing board now and work out a way of because I don't think it's practical for us to use this for all our kids and have to pay for it. So unfortunately, we thought we had it cracked, but then private enterprise got in the way, and now we've got to go back and start again. But I think this concept of trying to accurately and objectively digitise our movement outcomes in a way that's not just a research tool, but is something that you can put the child in the room next door, and you can do this from the age of 3 or 4. You know, they'll play in front of a screen. I think that would be great. So I'm sure there's some pretty clever people in the room who can work this out for us. Thank you.
Thank you. Thank you, David. Any questions? Dr. Nathan?
Sir, I'm using this Microsoft Connect as a gaming tool for my son.
Yes.
What I realize when we play with it, the bidimensional, it is good, but the depth is not that good. So are you able to, when you are doing this volume assessment, are you able to assess the internal rotation, external rotation?
Yes, you could see on some of those earlier pictures how we could create a three-dimensional balloon, but we're getting the child to do specific movements of reach as far as they can in a standardised position. And I think the problem that gets hard is when they put their hand behind their back, because but even in a Vicon system, and we did tried some patients in a proper gait lab environment with skin markers, even with that posterior part of the sphere gets difficult to assess, but it's not as accurate as a gait lab, but it's practical, and it's something that if we can get if we could produce the software that took the raw data from the machine and created the measurement, and it's also, I think, really powerful for parents, because you can show them where the kid's not moving and moving, and explain to them what you're trying to do.
It depends on the software and the multi-directional cameras, I think. That should be sufficient.
Yeah, I think if we could, this technique is cheap and applicable, but it's just the mathematics between the end of the machine and the data output.
Thank you. Best of luck.
We need to wind up. We are a little overshot with time. Yeah, Maulin, can I talk to David later on after the session? Thank you, David, for the wonderful session.
Thank you all very much again
for the good participation in this wonderful session. Thank my coach, Dr. David. Thank you.